Hello friends, today we are going to discuss about the extracorporeal membrane oxygenation. So extracorporeal membrane oxygenation is an advanced modality used to support the failing heart, lung or both. The support may be partial or full depending on the status of the cardiorespiratory function. So vascular access may be achieved centrally, peripherally or as a hybrid technique. Additionally, ECMO is an essential component of intensive care unit where its use is indicated in severe respiratory failure that does not respond to the conventional therapy. ECMO may be used as bridging therapy, that is bridge to decision, bridge to recovery and bridge to transplantation. Finally, ECMO may be used to facilitate resuscitation of the patient who are in refractory cardiac arrest. This is called as extracorporeal cardiopulmonary resuscitation. Now we will see what are the indication of VA ECMO and VV. VV ECMO should be taken into consideration in patients with potentially reversible severe acute respiratory failure that is refractory to optimal conventional management. So the indications for VV ECMO may be conveniently categorized into pathophysiological criteria based on scoring system, and specific clinical condition. So the pathophysiological criteria for initiation of ECMO are hypoxic respiratory failure, that is PaO to FiO2 ratio less than 80, despite optimal management, including trial of the prone position. Then hypercarbic respiratory failure with PCO2 of more than 60 and pH of less than 7.25 despite optimal ventilatory management. Now, the specific indication for VV ECMO other than respiratory failure in ARDS include severe air leak syndrome for CO2 retention in mechanically ventilated patient despite high plasma pressure, and for miscellaneous patient conditions such as airway support in patient listed for lung transplantation. Then, patient with acute respiratory failure unresponsive to optimal care. So we'll see now indications and contraindications for VV ECMO and VA ECMO. So VA ECMO is indicated in refractory cardiogenic shock, combined cardiorespiratory failure, failure to wean from cardiopulmonary bypass, breach to the ventricular assist device or transplantation, unstable refractory arrhythmias, cardiac arrest without return of spontaneous circulation, and massive pulmonary embolism. So, and this indication of the VA ECMO is severe ARDS, severe pneumonia, acute eosinophilic pneumonia, then this severe asthma, thoracic trauma, aspiration pneumonitis, inhalational injury, air leak syndrome, before and after lung transplant, bridge to recovery and transplantation, diffuse alveolar and pulmonary hemorrhage. Contraindications are ECMO are absolute contraindication include acute intracranial hemorrhage, massive stroke, acute bleeding, malignancy, severe aortic insufficiency, and immunosuppression. Relative contraindication includes advanced age, contraindication to anticoagulation, morbid obesity, end-stage liver disease, mechanical ventilation for more than 7 days, or PPLAT of more than 30 and PaFO2 of more than 90. Then types and technique of the ECMO. ECMO consists of two major types, that is veno-arterial ECMO and veno-venous ECMO. Then there are two subtypes of the veno-arterial ECMO, that is central and peripheral. So this is the diagram which represents the type of ECMO. So first one is veno-arterial ECMO, which is divided into central and peripheral. So central means the venous drainage is from the right atrium and arterial return to the ascending aorta. Peripheral VA ECMO includes venous drainage from the peripheral vein and arterial return into the common iliac artery. Now the VV ECMO is femoral vein to the internal jugular vein. It includes the dual lumen cannula and femoral approach. Then hybrid approach includes the veno-arterial venous ECMO and veno-pulmonary arterial ECMO. Veno-arterial venous ECMO, the drainage cannula is in femoral vein, extended until the IVC, and return cannula in the iliac artery and in internal jugular vein. Then veno-pulmonary arterial ECMO, it is indicated in case of isolated right heart failure, where return cannula is placed into the pulmonary artery. Now, this is the diagrammatic representation of a peripheral VA ECMO. Peripheral VA ECMO, that is the first diagram A is representative of peripheral VA ECMO, jugular carotid, that is venous drainage cannula is inserted into the internal jugular vein and into right atrium, and arterial return cannula is inserted into the carotid artery. Then B is representative of peripheral VA ECMO, femoral, that is venous drainage cannula is inserted into femoral vein, into mid RA, and the arterial return cannula is inserted via femoral artery. Then central VA ECMO, that is venous drainage cannula, is inserted into the RA, and the arterial return cannula is inserted into the aorta. So VA ECMO provides a rest to the heart by taking over the function of heart, perfusing the blood body. And VV ECMO provides rest to the lung by providing oxygenation and carbon dioxide removal. In VA ECMO, machine draws the deoxygenated blood from the systemic venous circulation. It oxygenates the blood and supplies oxygenated blood to the systemic arterial circulation for perfusion of the whole body. This is achieved by placing cannula into the right atrium for the purpose of drawing the blood, and placing another cannula into the ascending aorta for returning the blood. This is called as central VA ECMO. The peripheral VA ECMO, one drainage cannula is inserted into right femoral vein, the tip of which is positioned into the level of right atrium, where return cannula is inserted into the right femoral artery, with tip residing into the common iliac. So in VV ECMO, the three different configuration of cannulation are possible. That is femorojugular. That is the drainage cannula is inserted into the right femoral vein and advance until the inferior vena cava right atrium junction. The return cannula is inserted into the right internal jugular vein and advance until the mid right atrium. Then femorofemoral. The drainage and the return cannula are inserted into femoral vein on the either of the sides. The drainage cannula is advanced until the proximal IVC, while the tip of the another one, the return cannula, is advanced until the mid RA. Return cannula may be in the same femoral vein as the drainage cannula, or it may be in the contralateral femoral vein. Then dual lumen cannula. VV ECMO may also be configured using dual lumen cannula with one lumen draining blood from the inferior vena cava and superior vena. The oxygenated blood is returned to the RA through other lumen, with opening of the return cannula facing towards the tricuspid vein. Transesophageal echocardiography is useful in identifying jet of the blood directed towards the tricuspid vein. Hypoxemia during VV ECMO is maybe due to one of the following reasons. When patient's cardiac output is greater than the ECMO flow, the ECMO run may be associated with inadequate tissue oxygen delivery. In this instance, the ECMO flow can be increased in an attempt to increase and normalize oxygen delivery. Consumption ratio of up to 5:1, but certainly above critical threshold of 2:1. Increased metabolic demand due to sepsis, fever, agitation, shivering, etc. Then the another reason of the hypoxia is recirculation, which refers to oxygenated blood from return cannula reaching the drainage cannula without entering right ventricle due to proximity of the cannula into the right atrium. This leads to the poor gas exchange. This may be identified by oxygenated bright red blood issuing out of the drainage canal. And this may be avoided by ensuring that the tip of the drainage and the return cannula are at least 10 centimeter apart. In case of the femoral VA ECMO, the two major problems relating to the circuit and ECMO run may be encountered. When native heart recovers the function with the lung yet to recover, the upper body may be perfused with a deoxygenated blood emanating from the heart due to cardiac contraction. This leads to the upper body being perfused with the relatively deoxygenated blood, while the lower part of the body receives the oxygenated blood. This is termed as north-south or Harlequin syndrome. In such a cases, additional cannula is inserted into the right IJ that is connected to the arterial return cannula through the Y connect. The oxygenated blood passes through pulmonary circulation and return to the left atrium and then to the left ventricle, thus passing into the aorta. Thus, upper body gets perfused with adequately oxygenated blood. This configuration is also is called as a VAV, that is left ventricular distension occurs in patient with the on VA ECMO as a result of inability of the aortic valve to open in setting of increasing afterload and decrease in the cardiac contract. Additionally, myocardial blood flow from the Thebesian vein and bronchial blood return, and most importantly, systemic venous return that is not captured by the ECMO venous canal. This calls for the strategy to unload LV, such as placement of the LV vent, LV apical venting, arterial septostomy, or the use of intra-aortic balloon pump or impel. In a VPA ECMO, the return cannula is placed into the main pulmonary artery using graft, and the venous drainage cannula is either placed into the right IJV or any one of the femoral veins. Alternatively, dual lumen inflow cannula can be placed that drain simultaneously from IVC and SVC. Yet another technique is where cannula is placed via right IJV with its inflow port in the right atrium and its tip with the outflow port resides into the main pulmonary artery. The Seldinger technique is used for percutaneous cannulation using guide wire, and serial dilators or surgical cut down is done, followed by the insertion of the cannula. Surgical cut down is the preferred method and it is a non-emergent situation. Graft is placed over femoral artery to attach the outflow cannula to avoid limb ischemia. Now we'll see what is the outcome of ECMO. ECMO is the invasive therapeutic modality for resuscitation of the patients where severe cardiac, respiratory, and cardiorespiratory failure. Despite its increased utilization, ECMO may be associated with many adverse effects and complications. Also, registry showed decreased survival as treatment duration increases. Duration of the VA ECMO therapy among survivor and non-survivor was quoted to be similar in one study. The Smith et al. Concluded that survival was poor in patients who were weaned early, and survival was also poor in patients with long ECMO run. This suggests timing of the weaning is crucial to have good outcome. Survival decreases after ECMO therapy crosses 14 days due to disease process and treatment complication, adding cumulative effect. There is no effect on mortality with increased duration of the VV ECMO person. So about scoring, survival after VA ECMO can be predicted by means of survival after VA ECMO score developed by ELSO in conjunction with the Intensive Care Department of Alfred Hospital, Melbourne. This score takes into consideration age, diagnosis, cardiac and respiratory vital parameters, renal function and other organ function like central nervous system and liver function. It has a good predictive capability in the area under operating characteristic curve. So the same score is acute cardiogenic diagnosis group. That is, if it is myocarditis, then 3 score is given. Refractory VT and VF 2 scores. post-heart and lung transplantation, 3 score. In presence of congenital heart disease, -3. And other diagnosis leading to cardiogenic shock requiring VA ECMO, 0 score. Then age of the patient, if age is between 18 to 38, 7 score. If age is between 39 to 52, 4 score. If it is between 53 to 62, 3 score. If it is more than 63, 0 score. Then the weight of the patient, if it is less than 65 kg, 1 score. If it is 65 to 91, 2 score. If it is more than 91, 0 score. Then acute pre-ECMO organ failure. If in presence of liver failure, -3. In presence of central nervous system dysfunction, -3. Renal failure, -3. Chronic renal failure, -6. Then duration of intubation before initiation of ECMO. If it is less than 10 hours, 0 score. 11 to 29 hours, -2. More than 30, -4. If peak inspiratory pressure less than or equal to 20, +3. Pre-ECMO cardiac arrest, -2. Diastolic blood pressure before ECMO is more than 40, then 3. Then pulse pressure before ECMO is less than 20, then -2. Then bicup before ECMO is less than 15, -3. Constant value to add to all calculation of save score is -6. So total save score, if it is more than 5, then risk class is 1 and the survival is 75%. If it is 1 to 5, then the survival is 58%. If it is -4 to 0, then survival is 42%. If it is -9 to -5, then survival is 30%. If it is less than 10, survival is 18%. Now, complication of ECMO is circuit related and patient related. Circuit-related complication is thrombosis. This is the most common complication that can have devastating effect. Precise anticoagulation and constant vigilance are needed to avoid clotting in the ECMO circuit. Then circuit fracture may occur due to excessive pressure generation in the circuit. This will lead to sudden exsanguination of the patient and immediate placement of affected portion of the circuit or entire apparatus may be necessary. Gas embolism is the abrupt entrainment of air leading to the organ ischemia or devastating airlock leading to stoppage of circulation and is usually due to creation of significant negative pressure and air entrainment in the circuit. Cavitation in which gas is forced out of the liquid medium by circuit obstruction can also lead to gas embolism. Now the patient-related complication, neurological derangement. The causative factor for the neurological derangement are microemboli, hypocapnia, cerebral hypoperfusion, and loss of cerebral autoregulation. So in adult patient, the data shows the lower incidence of neurological complication with the VV ECMO compared to VA ECMO. According to the cumulative ELSO data, adult VV ECMO patients have 1% incidence of clinical seizure and 3.8% incidence of intracranial hemorrhage. Then adult on VA ECMO had 1.7 incidence, 1.7% incidence of seizure and 2.4% incidence of intracranial hemorrhage. The next complication is bleeding. Bleeding is the most common complication of ECMO, particularly from cannulation site due to systemic anticoagulation. Bleeding is known to occur in GI tract, brain, intrapulmonary, and retroperitoneal space. It is thus important to closely monitor the heparin dosage, activated clotting time, and activated partial thromboplastin time of patient on ECMO. Risk factors for hemorrhage in patient on ECMO are pre-ECMO cardiac arrest, sepsis, renal replacement therapy, influenza, hemolysis, and thrombocytopenia. So the arterial cannulation in VA presents higher bleeding risk compared to venous cannulation placed in VV. Now, the next complication is infection. Prevalence of hospital-acquired infection in patients with ECMO is 10 to 12%, with coagulase negative staphylococcus being major culprit, followed by Candida, Pseudomonas aeruginosa, and Enterobacterus. The infection risk increases with the duration of ECMO utilization. Other factors like translocation of the gut bacteria, ECMO-related impairment of immune system, colonization of oxygenator, catheters, and cannula are also other etiology. Then studies have found that the rate of infection is directly related to the duration of ECMO therapy. Then about renal dysfunction. Then this McAdisi et al. Have demarcated the phases of renal performance of patients receiving ECMO support. They have stated that first 24 to 48 hours in oliguric phase, which occurs due to inflammatory response of the body. This is followed by diuretic phase. CRRT is utilized to maintain the fluid balance of the ECMO. Then the Gilstein et al. Have demonstrated that survival is reduced in patients requiring CRRT when on ECMO. Now regarding ECPR. ECPR, the adjunctive use of ECMO in routine CPR, is recognized by the AHA and the European Resuscitation Council. Criteria for ECPR. Witness arrest. Arrest to first CPR less than 5 minutes. Initial cardiac rhythm of VF, VT or PE. Arrest to ECMO flow of less than 60. Low flow interval. Good quality CPR with ETCO2 of more than 10 mmHg before cannulation for ECMO. Intermittent ROSC or no or recurrent VF. Signs of life during conventional CPR. The absence of severe comorbidities and malignancy, and no known aortic valve regurgitation. Then regarding maintenance of ECMO, care of the patient on ECMO needs the multitude of healthcare professionals who understand the physiology of the form of the therapy. At bedside, nurse and the perfusionist are available 24/7 to monitor the patient. Lung protective ventilation is preferred if the patient is intubated. Those who are suspected to require prolonged ventilation may be tracheostomies. Patients are intubated if and when suitable. APG flow and the rotation per minute, sweep gas flow, pre and post oxygen membrane pressure are monitored periodically. The pre and post oxygenator partial pressure of oxygen is monitored to keep the track of oxygenator performance. Feeding is recommended, that is monitored by the dietitian. Renal replacement therapy is instituted as required. Then monitoring. Monitoring during ECMO is crucial. Monitoring will encompass the technical aspect of the ECMO and patient's physiological status. This entails the invasive monitoring such as arterial blood pressure, central venous pressure, pulmonary artery pressure, pulmonary capillary wedge pressure. The arterial pressure waveform provides information about mean arterial pressure and pulse rate. Invasive BP monitoring is also provides access for sampling for ABG. Anticoagulation on ECMO is achieved by unfractionated wet heparin, and options for monitoring are by means of activated clotting time, activated partial thromboplastin time, and factor 10AS. It is important to monitor anticoagulation on ECMO to prevent thrombotic complication, circuit clotting, and hemorrhage. The adverse effect of unfractionated heparin are heparin-induced thrombocytopenia, of which are two types, HIT1 and HIT2. It needs to be detected early and the patient should be switched to the other anticoagulants like argatroban and bevalirudin. It is very important to monitor for infection when patient is on ECMO using protocolized approach on the basis of culture and sensitivity report. Weaning from ECMO is a very complex task that requires multidisciplinary involvement. The approach to weaning will be dictated by echocardiographic parameters, lowering serum lactate level and adequate mixed venous oxygen saturation level in VA. In VV ECMO, reduction of the swept gas to maintain the acceptable gas exchange with radiological clearance will be necessary prerequisite. Ventilation is said to provide adequate gas exchange along with escalation of inotrops. Once it is confirmed that cardiorespiratory function is adequate, the ECMO is weaned off in OR or ICU followed by decannulation. Inability of the heart to exhibit adequate function warrants the continuation of the ECMO. This is considered as a failure to wean off ECMO, and alternatively technique is termed as AV bridge, which is utilized in ICU. Patient on VV ECMO are weaned when pulmonary physiology of the patient allows adequate oxygenation and carbon dioxide removal with minimal lung protective ventilation by reducing sweet gas. ABG is done hourly or half hourly during this process. Importance has been given to the presence of cardiac anesthesiologist in an ECMO team for initiating and managing ECMO inside and outside the hospital and transforming the patient on ECMO support. European consequences is also favor of strong role of cardiac anesthesiologist in the ECMO team. Transesophageal echocardiography helps in correct positioning of the ECMO cannula and assessing the cardiac function. Thank you guys.